Good morning, my lord.
Good morning, Mr. Stephen.
We have one witness this morning
One
to start
witness
with,
today.
my lord.
No, good morning. Thank you for coming. When you're ready, Mr. Stephen.
I'm obliged. Could you confirm your full name, please?
Kelly Marie Munro.
Thank you. And you've already helpfully provided a written statement to the inquiry, is that correct?
Yes.
Thank you. And for the inquiry's record, the reference number for that witness statement is SCI WT 0221-5 zeros and a 1. Just to reiterate at the outset, Ms Munro, that everything you said in that written statement will be taken into account by the inquiry, even if we don't touch on every single aspect of it in oral evidence today.
Okay.
And just a gentle reminder that the hearing is being transcribed and there will be stenographers taking notes, and no doubt His Lordship will be too, so just a reminder to try and speak at appropriate pace, and I'll try and do the same. Thank you. Now, you're here today to give evidence on behalf of the charity Carers Trust Scotland, is that right?
That's correct.
And how would you describe in headline terms the main purpose or aims of Carers Trust Scotland?
We are one of the national carer organisations in Scotland. We are a organisation that works with local young carer services. We, in my role, I work across strategic organisations, so COSLA, Scottish Government, local authorities, local young carer services, and I get to work with young carers as well, advocating for their rights and listening to challenges that they have.
Thank you. And I was going to come on to what is your job role, your title within the organisation?
My title is Education Officer, Primary and Secondary. So a lot of my work is raising awareness of young carers throughout education and the challenges that they have.
And how long have you held that role for?
Over 5 years now. 2019 I started, so June 2019, so over 5 years.
I think the main focus of your written statement, and no doubt evidence today, is on unpaid carers and specifically young carers. How many unpaid carers are there roughly in Scotland?
So there's the number that we identify with would be 66,000, but of that, with young carers, there's recognised there's at least 30,000 young carers in Scotland.
And when we're talking about young carers, what age or ages are we talking about?
There's no definition in the legislation that states a young carer as someone under the age of 18. Our services that we work with, our local young carer organisations, tend to support from ages 4 or 5 and up to 18, and then you have like young adult carers which are 18 to 25.
So potentially very young then. Yes. And I think the legislation you're referring to, you refer to this in your statement at paragraph 69. This is the Carers Scotland Act 2016 that you're...
Yeah, that's correct.
Thank you. How would you describe in high-level terms the range of responsibilities that young carers have, the things that they are typically asked or undertake?
It can range anywhere from helping with housework, looking after brothers and sisters, providing communication, right up to personal care. They can help with helping a member of family or the person they care for get dressed. They can deal with budgeting for the household. They can deal with shopping for the household, collecting and providing medication. They can accompany the cared for person to appointments. It ranges from everything they can do an hour or two caring a week, right up to 90 hours or more a week.
And I was going to ask, I mean, is that typically then quite a large part of their time spent on that role?
Yeah, it will vary. Every young carer is different, but it will vary. A lot of young carers, it will impact their day-to-day life. So everything from education to their own health and well-being, to even spending time with friends or engaging in hobbies and other extracurricular activities.
And you touched on it there, but is there a reality or expectation on young carers then that they have to balance or juggle those responsibilities perhaps with other things like education or employment perhaps?
Definitely, young carers that we have worked with in young carer services will report that, and that actually they often find tasks difficult. So perhaps in school they may find homework difficult if they're carrying out caring responsibilities when they go home. They often report that they can't take part in extracurricular activities, so hobbies after school, football clubs, perhaps a drama club, because they need to get home due to caring responsibilities, perhaps the same at weekends. And they also sometimes take time off school if they need to accompany a cared for person to a medical appointment, or if somebody is coming into the house and they need to translate, or perhaps they just need to support that person.
And to be clear, are you saying that would be the case even without the pandemic? And the pandemic is obviously
Yes.
something the inquiry is interested in, and we'll come on to in a moment.
Yeah,
but
that would be
that's the
without the
reality
pandemic.
for them, even out with that.
Yes.
Thank you. Now, against that background, I want to turn and discuss with you the pandemic. And I thought to start firstly with the closure of schools, if I may, and lockdown. Paragraph 12 of your statement, you say that even in advance of lockdown in March 2020, that your organisation was learning that a lot of young carers were already starting to get worried about going into school. What was the cause or causes of their anxiety at that stage?
So I think that the media had obviously been reporting. I think we had all seen that, but what we were hearing from young carer services and other young carers is they care for someone who would be potentially shielding. So they may have a terminal illness, they may be immunocompromised, and they were worried about being in school and getting the virus and taking it home to that person. Because with that, they were saying there may be guilt if they were passing that illness on, so they were really concerned about going into school because there was large numbers of people congregating, and they didn't want to pass that back home to the person they cared for, or other people in the house, but particularly the person they cared for, in case they would be, I think it was going to be admitted to hospital, or if they had, there was real fear around getting the virus and they didn't know outcomes of the virus at that point.
Thank you. In paragraph 13 of your statement, you say that your organisation had not yet conducted any studies. So how were you being made aware of these concerns at that time?
So we work with local young carer organisations in every local authority in Scotland, and we were reaching out to them just to say, do you need any support? We understand that it's uncertain times. Are young carers reporting anything? Do they need additional support? And this is what the workers on the ground that were interacting with young carers daily, this is information that they were being given and reporting back to us.
Thank you. In paragraph 14 of your statement, you say that anecdotally you became aware that young carers stopped attending school, university and respite services. And again, this is in advance of lockdown itself. Again, what were you being told or were you hearing was the reason for that they were stopping going altogether?
The fear of getting the virus. They'd heard at that point that perhaps somebody they knew or someone they knew had contracted the virus, and the fear was real, so they were withdrawn from school. Didn't want to go in. Again, this was information coming through from our young carer services. They were also stopping going to their young carer services that often offered respite groups. They were withdrawn from those groups as well, from real fear of contracting the virus and taking it home.
And when you say in advance of lockdown, do you know, again, it might be roughly how far in advance we're talking about? Weeks, months?
I think it was weeks. I don't think it was months. I think it was probably about 3 or 4 weeks before lockdown.
Okay. And that was having a chilling effect perhaps on their attendance in an education setting?
Yes.
Okay. Thank you. Now, if we turn then to when schools did indeed close, paragraph 16 of your statement, you say that young carers really struggled with the closure of schools. And in that context, you cite one of the surveys that was carried out by Carers Trust Scotland in June 2020, I think published then in July 2020. For the inquiry record, the reference for that is SCI-CTS triple X and then a dash and then 5 zeros and a 3. I won't take you in detail to that document itself, but I do want to ask you a few questions about it. This is the 2020 Vision hear me, see me, support me, and don't forget me. That's the document that I'm referring to. First things first, was the aim of that survey then to understand the experience of young carers during the pandemic?
Yes, we wanted to hear from young carers and what challenges they were facing, if any. We wanted to hear about their lived experience during the pandemic, and also to find out what more they needed support with, if there was gaps in areas that we weren't providing.
And do you know what the survey sample was that was taken at that time?
I can't remember off the top of my head.
No, that's fine.
I can.
I think in the document itself at the outset, I think it's around about 214 carers, aged between 12 and 25, I think. What did that survey tell you then about the impact of school closures upon the time, the number of hours that young carers were having to spend on caring?
It showed that young carers had an increase in their caring responsibilities when they're home. One of the figures that's in my statement relates to young carers. I think they show an increase of 6%, of up to 90 hours or more caring while still trying to engage in online education, and that figure rose to 11% for young adult carers, so those over 18. So if they're caring for 90 hours, they're still trying to do their learning at home alongside that, and the person they care for being there as well.
So was that, in your view, a significant increase in their caring responsibilities?
Yes, because they would normally be at school for I would say at least 25 hours a week if they were there in full-time education, where they would be focusing on their learning. They weren't in that environment, and they were then having to take on caring roles at home, more responsibilities at home.
And I think that same document talks about 1 in 10 young carers seeing their caring role increasing by 30 hours or more as well. Given that increase then in caring responsibilities, what did young carers have to tell you in that survey about the impact upon their education, specifically, for example, upon their ability to do their schoolwork?
They were finding it really difficult to engage in online education, because if they felt they had to check on the cared for person more at home, they were being interrupted during their online learning if they were able to get online. If they had siblings as well at home, that was a really hard environment. And I relate to it later in the statement, but also there's that being able to actually get online, the use of digital technology if it was working or if they had access to it.
Yeah, and we'll come on to digital inclusion in due course. I certainly want to cover that with you. I think at paragraph 51, just on this, the point about schoolwork or homework, I think you say in your statement that they were caring all day and struggling to do their homework. That was the reality for them.
That's correct. Yeah, they would, if they were able to engage on online learning, even if it was only an hour they struggled, then they would struggle to do further study around that. So they would stress about not getting their schoolwork done, but they would also be worried about the person, like not providing enough care to the person they care for. So they struggled to do that because of their caring roles or because of the home environment they were in. Was
that tension, that divided loyalties, if you like, you're talking about there between their own education and the person they were caring for, is that something that you were hearing from young carer organisations, young carers themselves? That would be correct. They had to engage in online learning for 5 hours, or to go and make lunch, to go and provide medication to the person I care for. So yeah, there was conflict there with them. Thank you. And you say at paragraph 17 of your statement that the feedback you were getting was that it was a difficult period, particularly if you were at home all the time, the young carer was at home all the time with a cared for person. Can you elaborate on the feedback that you were receiving in terms of respite, for example?
So normally at school, if a young carer was at school throughout the day, they would let us know previous to the pandemic that perhaps they phoned home to check on the cared for person, they sent a text. The odd young carer, if they stayed close, may go home at lunchtime. However, when they were home all day with the person that they cared for, even if they weren't the main carer, they still felt that need to check on them. to check if they were okay, if they needed medication, if they needed food, if they needed anything at all, any kind of support, particularly perhaps those with mental health. They perhaps needed a bit more extra support during the pandemic, so they felt they need to constantly check on them.
Thank you. Now, again, sticking with school closures and moving beyond, I suppose, schoolwork itself, you say at paragraph 37 of your statement, you say that when schools were open, young carers would be there, I think 25 hours a week. You said the same a moment ago, I think. And teachers who knew those young carers would be looking out for them, recognising if they were tired or troubled, for example, due to something that was happening at home, a family issue. Did that teacher supervision or pastoral role, did that go missing in your view during the school closures?
In our view, yes. When a young carer is in class or any learners in class, teachers are able to identify that through behaviours and in-person behaviours. Those behaviours are harder to identify. A lot of young carers go unnoticed because, or don't identify themselves because they're worried about social work intervention, they're embarrassed, they don't know they're a young carer. So for young carers that had taken on that caring role during the pandemic, it almost felt normal to them, or this is something they should be doing. So we feel like we were informed that a lot of young carers probably weren't identified during this time, and I think that shows the CMIS figures that we'll talk about later on. I'm sure the school recording system actually dropped with the number of young carers identified during school. So we feel that they weren't getting the support from school that they probably needed during that time.
Thank you. I think at paragraph 80 you say nobody was checking on them and nobody was recognising those responsibilities.
If they weren't attached to a young carer service and they weren't known to their schools, then no one was recognising the responsibilities they were carrying out during this time. There was no support that they were getting during this time, particularly if they had an increase in caring responsibilities or if they needed respite. These factors weren't being identified.
You talk in that same paragraph, paragraph 80, about, I think, perhaps an embarrassment sometimes about young carers. Is there a reticence amongst young carers sometimes to want to disclose the extent of perhaps the responsibilities they have?
Yeah, young carers have disclosed to us that it's taken time for them to recognise they're young carers or want to say that they're a young carer for fear of embarrassment. Now, the embarrassment may come around the condition of the cared for person, particularly if it's mental health or addiction issues. It may be embarrassment because they're having to help with personal care or dressing, or it may just be that actually their friends and peers don't do the same role as them, so they don't want to come forward and tell people what they do.
Thank you. Again, on school closures, you talk at paragraph 67 of your statement about young carers struggling during the pandemic to access healthy meals and food. Again, in your view, to your knowledge, did the closure of schools have an impact on young carers being able to access those things?
Yes, I would say when they're at school, they have access to canteen, they have access to food, they have access for those on free school meals, they have access to that, to school meals, and being able to have that break from their caring role while they're eating as well. And the report that we published, like 35% of young carers were struggling to look after themselves, and that could be because they're focused on the cared for person. So they want to make sure that they're eating and they're getting their medication and they're getting enough sleep before they look after themselves to do that.
Thank you. You mentioned at paragraph 68 that when schools were closed, some young carers at least were receiving wellbeing boxes of food. Where were those boxes originating from, do you know?
So some of the boxes I think were provided by the government or local authorities as part of the COVID pandemic, but they would often get ingredients that they didn't know how to cook with or they didn't have the life skills to do with. Local young carer services did have good practice initiatives where they would drop bags of ingredients at their door, and then they would have like an online cook along, so they were learning some life skills, where they would get to learn life skills, but also they would be able to have the chance to make a hot meal for them and their families, for families that weren't sure how to do this, or perhaps the young carer was the only one able to do that.
You mentioned that lack of life skills. Why was there that lack of life skills, do you think? Is that a reflection of age, or what's the reason for that?
It could be a reflection in age. You could have like 10, 11-year-olds that perhaps just haven't been shown how to cook meals or shop, or perhaps it was just that the main carer was now a key worker and out of the household, and it wasn't a skill that they had learned and had to do it as you went along. So there was different reasons for it.
In paragraph 71 of your statement, you also mention, I think, perhaps supermarket vouchers sometimes being issued to young carers. Again, was that something they were able to utilise?
So in some areas, families were given vouchers, and particularly for those in poverty, were given supermarket vouchers to use. But if the cared for person couldn't leave the house, then the young carer had to use them. But the vouchers were often for supermarkets many miles away, particularly in the Highlands and Islands. So either they had to travel by bus, because young carers may not have been able to drive, they may not have been at an age where, or been able to get a lift because it would have been someone out with the family. Or they had to walk a few miles. It wouldn't be their local supermarket that the voucher was provided for. It might be 1, 2 or 3 miles across town where they would have to walk to and then walk back.
Thank you. I want to move on then. With the closure of schools, delivery of education then moves online. And in paragraph 18 of your statement, you say that a lot of young carers reported struggling with online learning. Now, we'll come on to digital inclusion more broadly in a moment, but I wanted to start by asking, in your experience, was the home environment for young carers, many young carers, was that suitable for online learning?
The feedback that we received from young carers and young carers organisation was that it wasn't. It was difficult for them to engage in online learning. We held a focus group with young carers, and during that time, a few of the young carers disclosed that if they had a sibling that had a learning disability, was neurodivergent, even a physical disability, was keen to be in the same room, be on the Google Classroom with them. There was constant interruptions for them, and they wouldn't have had this interruption had they been in a physical classroom in school. So they found it really difficult to engage in online learning. Sometimes they just wouldn't go to the class if they thought it was going to be too chaotic, or they would have too many interruptions because they couldn't focus on their learning.
And is that a lesson learned, do you think?
Yes, I definitely would say it's a lesson learned, particularly for young carers. I think that they had no other choice. I don't think that they were able to take a laptop and go to a different room. I think that scenario would still work out in the same. I think that if they had access to school hubs, then it would have made life easier for them. Not to say that every young carer would have went to a hub, but the opportunity would have been there for them to get a break and been able to engage in online learning.
We'll come back to hub schools, but moving more to then to digital inclusion more generally, paragraph 30 of your statement, you say that numerous young carers and young adult carers were isolated due to being digitally excluded. Now, I understand that paragraph 27, that was an issue that was highlighted to the Scottish Ministers in a letter of 11th June 2020. For the inquiry's record, that document is SCI CTS XXX and then dash 5 zeros and a 5. And for completeness, at paragraph 28, you say that your organisation received a response to that letter in July of 2020. And again, for the inquiry record, that references SCI CTS XXX and then 5 zeros and a 7. I don't want to go into the detail of that exchange because the inquiry will move on to implementation decision-making phases in due course. But what I do want to ask you is, are there any particular examples of digital inclusion or exclusion that you would like to highlight to the inquiry? I think you cover a couple of these in your statement, but it would be helpful to hear those.
We heard from some young carers. One young carer had to use her mother's mobile phone to access education online classrooms because they had no other device in the house. They also didn't have Wi-Fi, so they were using sort of mobile data, and she found this really difficult because some certain apps weren't supported on it. The young person couldn't use that. Within there was another young person who was missing some online classrooms because the family only had one device. His mother was a full-time university student, and they were also trying to use that device for the cared for person's hospital appointments. Despite asking the school for further, and the local young carers organisation also asked for help with devices. The school had said that these devices had been passed to other vulnerable children, and unfortunately there was nothing else available for them. They repeatedly asked for printed copies of schoolwork, and this was never delivered.
And to sum up then, what was the consequence for them being able to undertake their education at that time?
They were digitally excluded. They weren't able to access online or education, or if they were, it was at very limited being able to access, so therefore they didn't have the same access as their peers that would have laptops or mobile phones, or so it had an impact on their education. They felt that they didn't get exam results that they wanted or access to study that they needed, so they felt that that had a big impact on their education and further education.
And just to be clear, these examples that you've given, these were highlighted to the Scottish Government, is that right?
Yeah, in the letters we sent to them.
Thank you. In your experience then, was there a consistent approach by local authorities to digital inclusion for young carers in Scotland?
No, every local authority was different, and every young carer had a different experience. One of the ones that I do highlight in my statement that we heard a positive story was in Stirling. Every person, every pupil learner in first year is given a laptop which sees them through the whole of secondary school. So they all have equality, they all have the same chance to have that. In other areas, there wasn't the same rules applied. Young carers were trying to get digital devices from their school. Their local young carer service managed to get some refurbished tablets or refurbished laptops from local businesses. Perhaps they got given grants which they were able to then purchase technology online and give a loan to young people. The other thing that we seen was where schools maybe like, here you can have a laptop or a tablet or a digital device. They were in areas where they couldn't get Wi-Fi, or it was really poor Wi-Fi or poor mobile data, so they were given the mobile phone dongles, but actually that wouldn't connect, so they would have enough to perhaps download one document, but they couldn't engage in a video classroom.
Thank you. I think in paragraph 29 of your statement, I think the phrase you use is a postcode lottery. Is that's your view in terms of digital inclusion across local authorities?
I would agree with that. There wasn't a consistent approach, and young carers were disadvantaged depending on what local authority they lived in.
Thank you. Now, you've touched on it there, but I'll come back to it now. At paragraph 34 of your statement, you highlight young carers in rural areas of Scotland, and I think you just said that perhaps their access and use of digital devices was not necessarily a straightforward one. Is that correct?
That's correct. So although they may have had the hardware, like in regards to a laptop or a tablet or a device, there was a lack of consideration given to young people in remote areas, and the lack of infrastructure there as well, because it's all very well given a dongle or a mobile Wi-Fi device, but if you're in a really rural area and can't get on, they had no option. They just had to not engage in their education.
And is it your evidence then that those in rural areas might have been more affected than those perhaps living more centrally in terms of digital inclusion?
Yes, and means to get online, yes, I would say so.
And is that a lesson to be learned, do you think, for the inquiry to consider?
I would say definitely in the future that infrastructure has to be there. If there's going to be more home learning or online learning, then the infrastructure has to be there and has to be given consideration, particularly in very rural areas of Scotland.
You mentioned grants for technology, and those perhaps were used, I think you say, for laptops, tablets, things like that. At paragraph 33, you talk about that. In your, or to your knowledge, was that application process for young carers to obtain those devices? Was that a straightforward application process?
The grants from their local young carer service that they had to apply for, so I wouldn't say the young carer had to apply for that grant. It would be done through a third sector service. It may not be a local young carer service, but actually that was additional resources that the service needed. So they were already quite stretched. It was during a pandemic. And then they had to do further resourcing of, it was Connecting Scotland, so they had to go through the application. I think somebody had to register to be like an online contact for them as well. So although there was grants available, it relied heavily on the third sector organisations supporting the young carers applying for those grants, buying the technology and then distributing that technology for them.
Thank you. I want to move on then to hub schools, which you mentioned slightly earlier on in your evidence. At paragraph 21 of your statement, you say that your organisation learned that the criteria for attendance for hub schools was set by each local authority. In your view or experience, were those criteria clear and consistently applied?
No, it was different in every local authority area. So in some areas, young carers were able to attend hub schools. They were part of the criteria and it was open to them if they wanted to attend. In other areas, they couldn't attend unless they met specific criteria. So if they were a looked after child or young person was one example we were given.
Because at paragraph 22 of your statement, I think you say that your organisation had a good relationship with certain local authorities who were flexible in approach. So that in that instance, young carers were able to attend hubs, is that correct?
Yeah, we had a meeting in one local authority, online meeting, with their quality improvement manager and the local young carer organisation, who actually said, yeah, they would open that up to young carers. And would there be specific young carers? Also, they were asking if there was any additional support they could give to a young carer. For example, would they prefer to be in a separate room so they weren't with other young people, to increase the risk of the virus. But it was, I'll go back to my previous one, it was a postcode lottery. The criteria was different in every local authority area, and I think for learning in the future, I think there needs to be national guidance rather than local guidance so that young carers aren't disadvantaged.
In paragraph 23 of your statement, you highlight that there were some young carers, I think you say those that were caring for those with mental health conditions or addiction, being denied attendance at hub schools. Do you know, or were you told the reasons as to why that was?
They were told that young carers, being a young carer, wasn't part of the criteria. They had limited spaces within hubs and young carers didn't meet that criteria. If they had another criteria, then they could apply under that, but they couldn't go because they were a young carer, it wasn't part of the criteria. They feel their education suffered from not being able to get respite from those caring roles and the trauma that they had to go through, particularly for those with addiction issues and mental health issues during that time. And to local authorities, that was highlighted to us.
Thank you. I want to move on now then to the reopening of schools. At paragraph 76 of your statement, you say, based on anecdotal information, that many young carers, I think around 3/4 is what you say, were hesitant to go back to school. What was causing that hesitancy?
I think it was the same reasons for withdrawing from school, but before lockdown I think the virus was still very much present. They were scared they were going to go back to school and pass it on. They were scared that people wouldn't be wearing masks, and that they had built up this bond with the cared for person, so they were also worried about if they weren't going to be there, who was going to do all these caring responsibilities that they had been doing during that time.
And in paragraph 50, I think you highlight a tension that you mentioned earlier. You're talking about a young carer voice online event for young carers, where I think the topic for discussion was the reopening of educational establishments. And you say that if young carers did return, they had to think not about their education, but the health and safety of the relative that they were caring for. Was that a choice that young carers were making you aware of, that they were wrestling with?
Yeah, they were worried about going back. I think they had to think about mixing with people not wearing masks. I think they were doing like the hand washing. Some young carers were reporting back that they were changing again before going into school and in case they were taking this virus back. And they were highlighting again that who was carrying out the caring responsibilities that they'd been delivering or they'd been doing while they were off school and at home. So a lot of this is going round in their head when they're back, and this anxiety is very real for them when they're back in education.
In paragraph 77 of your statement, you say that there were worries about ventilation within schools. I just wanted to ask if you could elaborate upon what those worries about ventilation were at that time.
I think some of the young carers were reporting back that like if they wanted windows open, then people were saying it was too cold, or it was too hot because some of the school's ventilation system, one young carer had reported back that perhaps she'd heard about ventilation carrying the virus, and they were worried about that. So that's the information that we had around ventilation.
And did all young carers return to school?
No, we've heard that some young carers withdrew from education completely. I think around that anxiety of bringing the virus back, or just their experience during lockdown, and they were already withdrawn from online classrooms. And I think also for those caring responsibilities, they felt that they were unable to return to school because the care wouldn't be there, replacement care wouldn't be there while they were in education.
I think in paragraph 66 of your statement you say that some of our young people lost their way in education and did not return.
Yeah.
Thank you. I'd like to move on now to the impact of the cancellation of the exam diet. This is something that you talk about in your statement, and the development of the alternative certification model. At paragraph 40 of your statement, you describe that policy change as causing worry to young carers. What were the main reasons for that concern?
So a lot of young carers were worried about the change because perhaps they hadn't done so well in their prelims. It may have been due to something that happened with the cared for person. It was a really anxious time. They weren't able to study as much. Perhaps their caring role had increased during that time. But following the prelims, they tried to make up for that. They tried to be in class more. They tried to be part of study more. So they were also worried that the results that teachers would give them may be lower because of their attendance due to caring responsibilities. So that was, they were reporting back that they were quite anxious and stressed about that, as it was going to determine their future on the grades that they got.
And were those concerns, those worries, something that was made known by your organisation to the Scottish Government?
Yes, we sent a briefing to the Scottish Government to highlight these worries around the exams. We also worked with SQA. We were part of a working group. However, the policy wasn't going to change around that, and we were informed to let them know about appeals processes should they want to do that. and we let all young carer services know that as well, and provided additional support.
And that briefing paper you mentioned, you have provided a copy of that to the inquiry, so for the record that references SCI and then triple X and then dash 5 zeros and a 9. Given what you've just said, how would you describe the impact of that policy change upon the educational attainment of those young carers?
They were really concerned. We don't hold what grades they got in school. We don't know what their attainment exam results were, but we did hear that through our local young carer services that some young carers didn't get the grades they were expecting, and went through an appeal process.
I think you say at paragraph 38 that the impact of this was life-changing for some young carers, is the way you put it.
Yeah, if they were hoping to get a certain grade to get into college or university and didn't get that grade, then it was life-changing for them. They had to go down a different path that they wanted to go down.
Thank you. I wanted to move on now to, I suppose, the change in the role for young carers during the pandemic. For example, at paragraph 19, you talk about how for some young carers, the pandemic changed the caring dynamic within the household. I think the example you give is if a principal carer was a key worker, they would then be out of the house more. And then at paragraph 24, you also talk about how young carers were having to backfill for paid support. You highlight that as an issue. So my question really for you is, given those increased caring responsibilities and this gap in paid support that you've highlighted, what respite was available for those young carers at that time?
The young carers didn't have any respite. They were at home 24/7 with the person they cared for. I think when the legislation changed and they could get out for an hour a day, if they were able to do that, then they could do that. But I think even then, if they were with someone that was shielding, they wouldn't leave the house. There was occasional respite where they could perhaps go on a tablet or listen to music, but they were in the home with the care person 24/7, and we talk about it in my statement later on, but young carer services would provide wellbeing boxes with perhaps like bath salts and colouring books for younger ones, or like sweets and hot chocolates and things like that, but there was no respite from the home. That would just be a small respite or a small luxury for them within the house.
And in your view, was that backfill in paid support something that young carers should have had to do?
No. Young carers were disadvantaged by having to do that back support, but they felt they had no choice. When support was cancelled, when day centres were cancelled, they had no one else to turn to do that support, so they took it upon themselves to do that.
Given what you said about the respite or lack thereof, was the social isolation of young carers a concern that was brought to your attention, to your organisation?
Yeah, young carers reported loneliness. They had no one to talk to about their caring role. They had no friends to socialise with. They couldn't really talk about their caring role if it was with a support worker or with friends, because more often than not the cared for person would be in the room with them or in another room where they may have heard. So they felt it was really difficult to talk about their caring role and any challenges that we're having.
And what about the ability of young carers to look after themselves in terms of their physical well-being? What were you hearing on that?
We were hearing that actually they were using all their energy for the cared for person, so when it came for them, there was very little sort of time and energy they used on themselves. They probably didn't eat the best. They were struggling with sleeping. There's increased in that report, the one that we referred to earlier, the Hear Me, See Me, Support Me and Don't Forget Me. They report increase in stress and anxiety of being at home.
I think you mentioned in your answer earlier the welfare checks, and that's something you talk about in your statement at paragraph 41 and 42, and I think that's something you say was another challenge for young carers. You say that prior to the pandemic, young carer support workers would have carried out welfare check-in sessions with young carers. What was the aim of those checks pre-pandemic?
So pre-pandemic, if a local young carers service and worker, if a young carer was registered with them, they would often go into school and do check-ins just to see how they were getting on with their caring role at home, to see if they needed more support perhaps with schoolwork, if they needed more respite, if they were wanting some group work, if they were perhaps going on a trip away from their caring role, or they just wanted somebody to talk to. Perhaps they were getting referred for counselling, more one-to-one sessions, or they would often have guest speakers come in and speak to them about certain conditions. So maybe like Deaf Blind Scotland would come in and speak about that. And then during the pandemic, the young carer workers weren't able to talk to them. It would just be through phone, and just to repeat what I said earlier, they were really reluctant to come forward and talk. I think the young carers workers were quite innovative, and they set up different WhatsApp groups and chat groups where they could talk to one another, but it wasn't the same as having that face-to-face discussion.
So pre-pandemic, these would have been face-to-face, but then schools close, and then I think alternative ways have to be found, as you've just described. And then I think you also go on to say, I think when restrictions ease, I think it says paragraph 44 of your statement, there was then sort of walk and talk was then possible, people could actually leave.
Yeah, they were allowed to, I think it's when you were allowed to see one person per day or two people per day, they could go out and do a walk and talk, and young carers were desperate to get out the house. They would get a takeaway hot chocolate, and even if it was raining, they were happy to walk round the park with an umbrella. But the young carer workers reported as getting some very detailed information from them, because it was maybe the only person they had seen all week, and they were being really honest about their caring role. So the young carer worker would often just take notes on their phone, because it's quite hard when they were walking around the park to try and get notes. And they noticed a massive change in this, from only being able to talk to 1 to 2 minutes online or on the phone, to actually these young carers being able to express themselves and any challenges they were facing.
And prior to the pandemic, school would have been one of those safe spaces where these meetings could have taken place.
Young carer workers would often set up in a room within a school and speak to 4 or 5 young carers within a day.
Thank you. I want to then move on to mental health of young carers, and you state at paragraph 53 that was a key concern of your organisation at that time. And again, we go back to the survey that we touched on in your evidence early on at paragraph 55. You say that there was a survey research done into the impact of the pandemic restrictions upon those young carers and their mental health. What were the key findings that came out of that survey?
Some of the key findings were that young carers are reporting that their mental health was worse than before the pandemic. 1 in 4 young carers were unable to take any break from their caring role. I think it's 74% young carers felt less connected to others since the pandemic, and 69% of young carers reported that they felt more stressed. One quote from a young carer says, "It's hard to care for someone when I can't care for myself," and that's within the survey.
To your knowledge, was there a particular group of young carers who were most or more adversely affected by mental health issues during this time?
I would say they would all be affected by mental health. I would say particularly those that were caring for someone with a mental health condition or those with an addiction were more were highlighted more, and probably that was one of the areas that we were seeing young carers report on if they were caring for someone with a mental health or addiction issues.
Thank you. And at paragraph 58 of your statement, I think you highlight that young carers not being in school when they were closed could mean that in some instances they were missing out on referrals to mental health services. Is that right?
Yeah, some young carers were saying that actually they had previously perhaps had a referral to CAMS, Child and Adolescent Mental Health Services, but we feel that others that would have benefited for it were perhaps being missed during this time, and they weren't getting the referrals that they otherwise would be getting, or additional support within school that would be happening if there wasn't a pandemic and they weren't at home.
And at paragraph 56, I think you also mention school nurses, and I think when schools were open, referrals for wellbeing assessments would be possible, but again, when schools closed, is that something that was off the table?
Yeah, young carers were referred to school nurses. Well, no young carers that had reported to us that they had any referral to school nurses, whereas within the school, if the young person particularly is going through a bad time, or if they feel they need more support, then they should be having a wellbeing assessment, if the young carer agrees, obviously, but that didn't happen during the pandemic.
What coping mechanisms for mental health were available then, given what happened?
I would say that they had their local young carer service, who did do the check-ins that were available. They had wellbeing boxes. Young Scot provide a local young carers package, where they were able to get, it used to be in person, that they could access like in-person discounts, in-person cinema vouchers and things like this, but this moved online and they were able to access sort of like mental health apps. They were able to access subscriptions to certain like movie subscriptions or music subscriptions, but a lot of the time the cared for person, they would pass this on to the cared for person because they felt that they needed it more, rather than use the respite for themselves.
Thank you. Now moving on then to the lessons learned, I suppose, section of your statement. There was one I specifically wanted to ask you about. At paragraph 84, you identify a lesson to be learned. You say there needs to be more robust data around young carers in school and more accurate recording of their attendance and attainment. Why do you consider that to be important?
Because I feel that if more young carers were recorded within schools, if there was more accurate recording, then they could get more support that they're entitled to. Young carers weren't identified during the pandemic, and I think even those that were recorded in school should have had more support. So if all education professionals are trained to identify young carers, then they will receive the support they're entitled to. I think stronger working partnerships with the third sector, particularly young carer service in schools, would also provide more support and more young carers being identified.
Thank you. Are there any other particular lessons to be learned or things that we haven't covered today that you'd like to mention at this stage?
Just that I think that all children and young people should have equal access to digital technology and digital literacy to allow them all to have equal opportunities within education, and increased availability of counselling within schools because the pandemic was a traumatic experience for them.
Thank you. My Lord, I don't have any further questions for the witness, subject to anything you may wish to
No, I've got no questions. You'll be pleased to know, Miss Munro. Thank you very much for your attendance and your evidence today. And that brings an end to this session, and we'll come back a short time at 11:15. Thank you all very much.
Please rise.
Now, good morning, Ms van der Vesterhuizen.
Good morning, my lord. My lord, our next witness is Mr. Glenn Carter, who is the head of the Scotland office of the Royal College of Speech and Language Therapists.
Very good. Good morning, Mr. Carter.
Morning.
Right, when you're ready. Ms.
Thank you, my
van der
lord.
Vesterhuizen.
Morning, Mr. Carter.
Good morning.
Could I please ask you to confirm your full names?
Glenn Allen Carter.
And you gave a witness statement to the inquiry, and my lord, that statement can be found using reference number WT0643. Mr. Carter, you say in your witness statement that you're a qualified speech and language therapist and that you've worked in the NHS in Scotland for 23 years. Is that correct?
That's correct.
And for how long have you been in your current role as head of the Royal College for Speech and Language Therapists in Scotland?
2.5 years, almost 3 years.
And immediately before that, you say you led a children's speech and language therapy service in NHS Forth Valley. Is that correct?
That's right.
I understand from your statement that the Royal College of Speech and Language Therapy is a professional body representing speech and language therapists in the UK, and it has approximately 22,000 therapists in the UK, of which approximately 1,100 are in Scotland. Is that right?
That's correct.
Could I please ask you to outline broadly what the aims of the Royal College of Speech and Language Therapy are?
Yes, broadly the aims of the Royal College of Speech and Language Therapists is to promote the speech and language therapy profession and to improve the lives of people with communication and swallowing needs.
Thank you. And how does it do that? I'll come on to ask you about the role of speech and language therapy, but broadly, how does the Royal College do that?
So there's a number of ways, one of which is professional support. So we develop guidance, tools, resources and training for speech and language therapists. Also, we promote and support quality research and evidence to advance the effectiveness of speech language therapy, and also policy and advocacy, where we seek to influence national and local government to ensure the policy is high quality, mature, and that it represents the needs of people with communication and swallowing needs.
Thank you. Before I go on to ask you about the role of speech and language therapy in educational contexts specifically, please could you explain briefly what speech and language therapists do more generally?
Yes, so it's a broad remit. So people talk about it from a cradle to grave service, but sometimes it's pre-birth, where we're supporting new families to understand the importance of speaking to their babies and promoting language development, but right the way up to end of life, where that could be working with cancer patients, stroke, motor neuron disease, and everything in between. So speech and language therapists, there's two main areas they work in. There's communication and eating and drinking, which is known as dysphagia. On the communication side, 20% of the population will experience some level of communication need in their lifetime, and that is a very broad range. So for children, it could be around their ability to produce sounds, speech sounds, for instance. Traditionally, people view it as difficulties with stammering or lisp, but it's broader than that. So it could be with children. Some children struggle to understand and express spoken language as if it's a different language for them. But also there's issues with voice, how they use their voice, and social communication. For adults, there can be acquired neurological conditions that affect communication, like stroke, motor neuron disease, Parkinson's, dementia, and on the dysphagia side, eating and drinking, there's 1 in 17 people will experience some level of eating and drinking difficulties in their lifetime. For children, that could be about their ability to suck, to wean, to manage solid foods, sensory issues around that. And for adults, again, quite a high proportion of acquired conditions can come with dysphagia. For instance, stroke patients, 50 to 75% of them will have some form of eating and drinking difficulty. And speech and language therapists work in a range of places, so it can be in the home, in nurseries and schools, care homes, acute hospitals, also justice settings as well.
Thank you. In your witness statement, in particular at paragraphs 11 and then at 16 and 18 to 19, you refer to the importance of communication and spoken language skills for children's development and for longer-term outcomes. Could I ask you please to spend a bit of time explaining some of what is known about this?
Yes, communication is core to who we are as humans, and the important aspect is about the ability to connect with others. So when communication is broken down or hasn't developed, then that can cause distress. So that can be a range of issues where either there can be increased behavioural difficulties or challenges with interacting with others, with learning, etc. And so the distress can lead to behavioural issues or indeed low mental health and depression. So there's lots of evidence to show that communication is core to children's ability to learn, to their mental health and their future life chances. We know that if children have difficulties with their vocabulary at the age of 5, they're 3 times more likely to have mental health difficulties when they're older. We know that 88% of young unemployed men have communication needs, and 60% of young people in contact with the justice sector have communication difficulties.
Thank you. And at paragraph 11, specifically, you refer to the fact that if a child has a communication difficulty, then that's likely to affect their ability to learn and access the curriculum, their ability to interact with peers, and to manage and navigate the playground. And that impact is wide-reaching and is important to prevent harm. Would you care to elaborate a little bit on that, please?
Yeah, I think it's important to know how important spoken language is for learning within that context. So it's the foundation on which learning is built. Much of teaching and learning is predicated on language of some degree, whether that's spoken or written language. And therefore, children who struggle to communicate in any forms I've described will find navigating school and the curriculum very challenging. Communication is a dynamic skill. It's one of the most complex skills that humans learn, and therefore being able to make friends and navigate friendships, navigate the challenges of the playground and understanding what's said and what's not said can be quite difficult for children with communication needs.
Thank you. And you've already touched on it in your explanation about the consequences of it, but mental health in paragraph 18 you say is closely linked with communication skills, and there's also a connection between spoken language abilities and behaviour. All behaviour is a form of communication, and we know when children have communication difficulties, they can become distressed and will find different ways to convey that their needs aren't being met. And you say that this is manifest in low mood, disengagement with learning, or in more disruptive behaviours. We'll come on to discuss some of the studies that were undertaken during and just after the pandemic. But is there anything more that you'd like to elaborate on this link between communication skills and mental health?
I think the nature of communication difficulties is lots of children can go under the radar, particularly if they're not acting out in school or at home, and their mood is quite low, and they just get by and go under the radar. I think the challenge of behaviour is that it can mask a lot of difficulties. So if a child is particularly challenging behaviours, then that's what the focus is on, rather than the cause of behaviour, rather than how they're feeling about the lack of contact and connection within the home or school environment.
Thank you. I'd then like to move on to ask you about the role of speech and language therapy in educational contexts pre-pandemic. If you could ask you first to please explain some of the different types of speech and language communication difficulties that speech and language therapists work with children in particular.
Yes, so in terms of education settings, whether that's nursery or school, there's a very wide range of difficulties that can present. I mentioned speech sound difficulties. Some children can be quite unintelligible and find it difficult to get their point across, which can lead to high levels of frustration and anger. Interestingly, with the speech sounds, that's very closely linked with the ability to read and write, because it's about phonemes and sounds, and so their ability to distinguish between sounds to process what's being said, and anything that happens within spoken language is translated into written language. There are children with issues such as developmental language disorder. I think people understand dyslexia far better than developmental language disorder. Dyslexia is obviously a specific difficulty in reading and writing, whereas developmental language disorder is a specific difficulty in the ability to express and understand spoken language. But it also has an impact on written language. These children, some of them are very good non-verbally, they're good socially, and they're good at copying their peers. And so sometimes right up to P3, their difficulties aren't apparent because they get by navigating the environment, being hypervigilant about what's going on and anticipating what they should do. However, when the attainment levels increase and the demands on them increase, then that's when it starts to become much more difficult for them. So the speech language therapists will seek to observe children in the context of education, identify what strategies they're using, what strategies would be helpful to navigate the educational context, and also to assess their communication and understand what the range of vocabulary that they have, their ability to understand what's being said. Can they follow complex instructions or not? And do they understand the nuance of social communication?
You talk about the types of speech and language difficulties and communication difficulties you work with in paragraph 25, and specifically you talk about you're assisting children with delayed spoken language skills who present as much younger than they are when they come to school or nursery. And you say that there are quite a lot of environmental factors that play a part in that. Would you care to elaborate on that, please?
Yes, so our members and educators are saying there's a large number of children come to school with inadequate spoken language skills for learning, and that can be presented in lots of different ways. But the reasons for that are complex. I suppose it's important to understand the different types of needs that they can present with. They present with specific difficulties or difficulties that you might expect a younger child to present with. And so those environmental factors are really important, and the pandemic shone a light on some of that. Is around their access to quality interactions, their experience of the world, how high quality adult-child interaction is within the home or within the educational placement. And it's a complex situation, but a lot of factors impact the child's ability to learn that language and whether they've been exposed to enough words or enough high quality words.
Thank you. And you also say that you assist children with specific speech and language difficulties where there's a genetic element and they are born with those needs. What type of needs, could you give some examples of what those look like?
Yes, so there's children who are born with risk factors, whether that's genetic, biomedical, neurodevelopmental. Those children sometimes described as disordered, so atypical communication needs, whether that is children on the autism spectrum, attention deficit disorder, speech disorders, language disorders, voice challenges, dysfluency, a huge range of needs.
And you also say that you work with children who have very high complex high level needs, where you might have to use augmented and alternative communication. Could you please elaborate a bit on that as well? Yes,
that's right. There's children who have complex needs, whether that's physical and learning disabilities, who are perhaps non-verbal or have very limited verbal communication. Speech and language therapists will seek to facilitate their communication to a range of means. That could be low-tech aids, which could be pictures. It could be high-tech aids where children utilize eye gaze devices where they can look towards a particular picture and the device will say the word. And high-tech aids where there can be lots of complex programs on iPads where children can access through switches or accessing with their finger to touch a range of pictures to communicate their point and their needs and their wants.
Thank you. Just continuing in relation to the role of speech and language in educational context pre-pandemic, you noted paragraph 7 of your witness statement that speech and language therapists are primarily employed by the NHS, but that most local authorities Sorry, I'll wait till we get there. You say that they're primarily employed by the NHS, but that most local authorities have a service level agreement to provide SALT services within educational contexts. Could you please just describe how speech and language therapy services are traditionally provided out with educational settings?
The traditional model of speech language therapists would be within community clinic settings where the families attend the clinic in a central position, and it would be one-to-one therapy where the therapist works alongside the parent or a therapy partner with that child to identify and support and provide therapy for their particular needs.
And could you please then explain how and to what extent speech and language therapy services were integrated into educational settings in Scotland prior to the pandemic?
This was variable across Scotland and does depend on the level of funding that local authorities provide. So it's quite patchy. I would say that the majority of local authorities in Scotland do have a service level agreement with the NHS to provide those services, to provide speech and language therapy in mainstream schools or in more complex special schools. Funding for speech and language therapy is reducing from local authorities and from health boards actually, which is impacting their ability to provide some of these services in educational contexts, and has been reducing for a number of years. So that will affect how consistent or how much speech and language therapy can provide in that context. Sometimes if the threshold resource is not sufficient, then they have to centralise and provide speech and language therapy within a community clinic, for instance.
So please could you explain what speech and language therapists do in educational settings and the different levels of speech and language therapy support that is provided within those settings, and specifically prior to the pandemic? And I think you referred to universal, targeted and individualised therapy. If you could please explain a bit about each of those.
So we described the traditional form of speech language therapy. Evidence and practice has moved on from then to show the importance of providing support and approaches for children in the context in which they function, whether that is in the home or nursery or school. That is to acknowledge how key communication is for learning and well-being, which is the key outcome for education, but also to acknowledge that the biggest impact sometimes happens within an education context. So that by that I mean the dynamic and varied environment in which children function in. We have to ensure our approaches and our aims are relevant for that child, and that we are working on what's most important for them. What are the barriers to them learning? What are the barriers to them interacting and then participating in an education context? The model which we've described is what we should expect is high quality provisions at universal, targeted and individualised. The traditional model is that whenever there was a concern, it would go straight to the individualised. But what we know from research is how important it is to have the whole environment supported around the child. So universal offers, we know, for instance, if you improve children's vocabulary, you improve their attainment, whether they've got communication needs or not. In the context of an early years setting, you would hope that adults are interacting with children in a way that will promote their language development and not get in the way of that. So that could be a universal offer where speech and language therapists can work with early years practitioners to support and promote behaviour change in how they're interacting. And that could be about getting down to the child's level, commenting on what the child is doing, repeating back what the child is saying and adding language to it and avoiding lots of questions.
So could I ask you just to pause there? So practically, what is the role of the speech and language therapist compared to the early learning and childcare practitioner, for example? How do they interact to deliver this universal support?
So in that context, the speech and language therapist is a facilitator where they're functioning within the environment. We know how important it is for them to develop relationships and trust, to make it feel safe for those practitioners to change their practice. So they will there in a coaching and modelling role. We sometimes use video feedback. We video the interactions of the practitioner with the child, and then we spend time dissecting that and discussing ways in which to facilitate communication. So in that context, speech and language therapist is there to facilitate and promote and develop the skills of the practitioner.
And then if you could move on to explain a bit more about targeted, what sort of children would require or targeted interventions, and what do those look like in practice?
So what we would hope is you can meet the needs of quite a lot of children at the universal level. If that's not adequate, then it would move up to targeted level, and that's about giving a bit more concentrated support for a group of kids perhaps who require a bit more additional input. Sometimes that can be working with a practitioner to give advice about how to promote the needs of these children. Practically speaking, that could be facilitating group interventions around developing vocabulary, having fun with words, improving their ability to tell stories. And the therapist, again, is always about building the skill of the people who are there all the time with the child, rather than the therapist who could be coming in once a week or once every 3 weeks. And if that's not adequate at the targeted level...
Sorry,
go on.
Mr. Carter, before you move on to the individualised, could you please just describe some of the communication and speech and language issues that would require targeted intervention? So
the type of difficulties you may come across are children who have got very limited vocabulary. They've got, they use perhaps very general words rather than specific words to get their point across. The use of verbs is very important. That's the core of a sentence. And so if they're using very general all-purpose verbs like doing, it makes it very difficult for them to get their point across. So it's about expanding their vocabulary of nouns, but also verbs, and being able to help them structure a story in such a way that they can communicate it in a well and complex way, which will then support their reading and writing in later years.
And that type of targeted support, would that be for a group of children?
Typically, it's a group of children who require more than the universal offer, or in addition to the universal offer. So those children can have identified needs of specific speech and language difficulties, or they could present with communication needs that are behind what we would expect for their age.
And then if I could ask you to move on to discuss the individualised support.
So the individualised support in the context of an education could be the speech and language therapist comes in, observes the child in the real context, works out how they're interacting, if there's any barriers to their ability to participate fully in that setting. Meeting with their key person or with the teacher, and giving advice and strategies about how to promote that child's communication in that context. Sometimes that requires individual assessment where the child is seen by the therapist. They provide standardized assessments to work out what their age equivalent is on comprehension or expression, and then using all of that information to develop a plan in partnership with educators to see how do we promote, what aims are we going to be working on for these individual children. They're the children who require a bit more specific attention. Perhaps their needs are a bit more complex, and it needs a coordinated approach. That could also involve actual therapy about identifying what the need is and providing support. So an example of that would be colour coding sentences to be able to understand what needs to be in a sentence, whether that's the subject, the doing word, the verb, and the where and the when. And we can do that in lots of fun ways, which includes signing, colour, and a huge range of activities which promotes children's communication. It should feel fun to the child.
And is that delivered one-to-one? Is that delivered to an individual child?
That's right. So some of those interventions I've just described could be delivered even at a whole class or at a small group, but also at a one-to-one. But the children one-to-one perhaps need a bit more focused attention, more regular input, more reinforcement or differentiation for those activities.
And in terms of embedding of speech and language therapy within educational settings, what are some of the benefits of doing that?
This is having done this for many years, the key to embedding these type of approaches where people feel empowered to support and promote spoken language. It's all about getting the speech and language therapist in the context regularly and building up relationships with teachers, with early years practitioners. So you're working alongside them. You're able to have those conversations in the staff room, those corridor conversations where you check in with each other, and you're building trust. And so the therapist is learning from the educators is learning from the speech and language therapist. So it's not about giving the educators more work to do. This is about everybody's business to promote spoken language, and the therapist is there as a facilitator. And yes, to provide quality provisions at all the levels we've described, but it's the relationships and the trust that is key, that supports the effective development of children's communication.
Thank you. You've already touched on and suggested that it's not consistent, or that provision pre-pandemic was not consistent across Scotland prior to the pandemic, especially in relation to education settings. And I think in your witness statement, you talk about some of the reasons why it was not consistent, and you talk about depends on funding available, and you also talk about recognition in an Equity for All report that highlighted this variability. Could you please elaborate on some of the reasons for that variability and what was recognised in terms of this lack of consistency pre-pandemic?
Equity for All was a report commissioned by the Scottish Government, where for the first time in the world that we know it, we were able to map the needs of a country. And so because we've got high quality prevalence data, we were able to map the need across Scotland, align it with local information about deprivation, etc., and able to demonstrate that there's 275,000 children with predicted communication needs in Scotland. That report was able to demonstrate that for the areas of highest need in Scotland, there was the lowest level of speech and language therapy resource. It also identified that there was areas where speech and language therapy provision was inadequate to meet the needs of the population at that local area. So that points to a postcode lottery, if you like, in terms of the level of support and provision in place across Scotland and where the resource should be positioned. And so there's definitely inequity across Scotland. There's inequity in terms of funding from health, but also local authorities in terms of level of funding. And the funding, the transformation and working that way is important, but you need a threshold resource to be able to do that. So where the resource isn't available, it forces the hand of the service to centralise speech and language therapy and perhaps bring it towards community clinics and be working more of an isolated way than a more integrated way, which is where the research and practice suggests it should be delivered.
And just in relation to differential service provision, you also refer in paragraph 21 to the fact that there was pre-existing inequality which was exacerbated by the pandemic. We'll come on to discuss the impacts of the pandemic. But you say in respect to the level of provision provided in areas of socioeconomic deprivation, i.e. areas with the highest need, have the lowest level of speech and language therapy resource available. Families living in poverty really struggle to access services where they have to travel distances or pay for that travel. This is another reason why it's so important that speech and language therapists can work where children are situated. Would you care to expand on that pre-existing inequality? Is there anything to add to what you have in there?
I think the very concerning element of this is that we should be providing the highest quality support for those in greatest need. And typically families living in poverty are one of those groups, and our concern is that even pre-pandemic that was not the case, that we weren't able to provide that high quality service to the most in need, and people living in poverty find it very difficult to get to particular central places or to get to buses or to engage in speech and language therapy, to follow it up, given how stressful their lives can be, and the impact of lack of income to be able to support that type of approach. So that just underlines the challenges we were facing even pre-pandemic.
And further in relation to inequalities pre-pandemic, at paragraph 15, you talk about there were inequalities for children and young people with speech and language difficulties pre-pandemic, and you say one of the most prominent inequalities relates to delays in spoken language skills, and you refer to a Scottish study finding that 50% of children who start school present with inadequate spoken language skills. Then you go on, and as a speech and language therapist, I observed that children who were 15 or 18 months behind in their peers in respect to these skills from the very beginning, these children have to play catch up. So was that pre-pandemic?
That was pre-pandemic. That study is actually quite old. It hasn't been refreshed recently, but it points to something our members and educators are saying, that this was in place. We were seeing a lot of children coming to school with inadequate spoken language skills for learning, and well behind what you would expect for children of that age. So, you know, even before the pandemic, you would experience some children coming to school with very, very little spoken language, and therefore struggling to catch up with their peers and to try and close that gap.
And were there any particular groups of children manifesting in these difficulties?
Yeah, typically it's the children living in poverty, areas of social deprivation, that were presented with more of those spoken language difficulties pre-pandemic.
And is it known what the reasons for those difficulties are?
Yes, so that is related to their exposure to new experiences, the level of interactions, the exposures to words, their access, or how consistent their access was to early years placements prior to coming to school, and the stress that the families were experiencing at that point.
Thank you. Could I then ask you just to explain briefly the role that health visitors play in identifying and referring children to speech and language therapy services, please?
Yes, health visitors have a very important role in identifying need. They get alongside families and visit them regularly, and they measure a number of areas of child development and identify communication needs. Quite often they're the first port of call. Speech language therapy receives a lot of requests for assistance or referrals from health visitors for children who they're concerned about who aren't meeting their milestones, so they've got a very important role.
You also explain, or perhaps you can explain how important it is, early identification is of issues in relation to speech and language, and how important that is for long-term outcomes or successful outcomes.
Yeah, the identification early is critical. It's different from, for a child to develop, you get the most development in the early years. The first 1,000 days, the first 3 years of a child's life are particularly important for that language development. You can, if you get in early, it is far more effective. There's more development. It saves money in the long term, and the children, in terms of long-term outcomes, communication needs are critical. And so if you don't get that development and improvement, then they will find it very difficult to interact with others, to engage in nursery or school, and be able to ultimately, I think there's sometimes a thinking that if we close the gap at a certain point, that gap will stay closed. However, the research does demonstrate that you need to keep engaging with those children to maintain improved communication throughout their school career in order to achieve positive outcomes.
So you've identified the importance of health workers, health visitors, but what, if any, role do early learning and childcare practitioners and teachers play in identifying and referring issues in relation to older children?
Yeah, we get a lot of requests for assistance, and they see these children very often, and will refer them to speech and language therapy. They get to see them in context. They get to see how they're functioning with their peers and whether they're able to interact with adults or otherwise, and they are therefore also very important in identifying need early.
Thank you. Mr. Carter, I'd like to move on now to discuss the impact of pandemic restriction measures, including the closure of early learning and childcare settings and schools, on the provision of SALT services. We've just touched on health visitors, but could you please, just if you can, give an indication of to what extent disruptions to health visitor assessments and newborn hearing screening impacted on early identification of speech and language difficulties during the pandemic?
We know that health visitors struggle to access families during the pandemic. They will have had fewer appointments. They had to move to remote offers, telehealth offers, which have led to fewer appointments, incomplete data, and therefore, as the first port of call, the fact that they didn't have access to families meant that we weren't identifying children early, and there was a significant dip in requests for assistance at one point during the pandemic because of that.
in relation to health visitors, you note in paragraph 22 of your statement that they noted a significant spike in around the 27 to 30 month mark that was concerning, and that this also was also observed in Public Health Scotland data. Could you please explain in a bit more detail what was observed and why it's concerning?
Public Health Scotland produced a few excellent reports on this. They monitor health visitor data. Health visitors engage with children across their development, including 13 to 15 months and 27 to 30 months. They notice a significant peak in concerns about communication. Now, health visitors monitor many areas of child development. It's important to know that pre-pandemic communication was the highest area of concern anyway, sitting about 10% of that 27 to 30 month. From January 21, Public Health Scotland noticed a significant peak, a significant increase compared to pre-pandemic levels. This peaked in August 2021 and actually has remained above pre-pandemic levels till now. This is particularly concerning because the time that these children are being assessed is the critical time for children's language development, and so Public Health Scotland noticed it and were flagging it up as a concern, and health visitors were saying they were seeing far more of these children with the area where the most concern was communication. Interestingly, you can differentiate between children in the highest areas of deprivation versus the most affluent areas. For those in the highest areas of deprivation, it was sitting about 20% plus along that timeline, and for more affluent areas, it was sitting about 7 or 8 or 9%. So there's a significant difference between the two.
And again, what were some of the reasons for the spike and that differential again?
So the reasons are complex. I suppose that if we go back to the different types of children that we have, we've got the children we were born with risk factors, with communication needs. We've got the other children who have a socioeconomic disadvantage. The first children with specific communication difficulties, what we've noticed is that having come to services, speech and language therapists and educators, they're noting far more complexity of need, and they are noting that these children have experienced more harm, struggling with their mental health, struggling to engage with education, and that will have been because of the lack of access to the services. The other children with socioeconomic disadvantage, the research seems to be showing that the reasons for that peak was because of seeing their worlds become much smaller. They were seeing fewer of their family members and friends, and therefore interacting far less. They also weren't experiencing the world. Learning language is a dynamic process where you need to experience different parts of the world. Going out to see stuff, seeing animals, etc., helps develop vocabulary, and also lack of access to education. I think there's a very significant point here, is that stress has had a significant impact, and points to why we saw the spike. For families during the pandemic, they were experiencing much higher levels of stress. They were struggling with homeschooling, home working. They found it stressful to manage all the demands, particularly around economic demands. We know the more people went into poverty. And when you consider even at a baby level, what you're hoping to see is a mother or father being responsive to the baby. So the baby makes a noise, babbles, smiles, and it's called serve and return, where you try and have good quality interactions. We know when families are experiencing stress that serve and return and the opportunities for those types of interactions is reduced significantly. Those serve and return at the baby levels is really important for activating the baby's brain to ready themselves for more communication and future development. You can scale that up to the peak that we saw around toddlers. Again, it's important about this adult-child interaction, where they have high-quality interactions at home and wherever they are. And so there's good quality research to show that actually the conversational exchanges, there should be a significant number of them per hour. So there's some research which suggests that the optimal number is about 40 per hour. Now it can be more than that, it can be less than that, but around 40 is the optimal range for promoting language development. If that is very, very low, so 5 and below, that's a very serious issue where children are in language deprivation and are struggling, will find it very difficult to develop the skills that they need in future life. So I think stress is a very important factor in all of this. We're still seeing it. Families are still experiencing very significant levels of stress, but that impacts families' ability to play, talk, read, sing with their children. These are all things that help promote language development.
Thank you. We'll go on in a moment to speak about redeployment of speech and language therapists in Scotland, but if we could just pause to discuss some of the other observed increases in speech and language difficulties that were observed. So please could you explain some of the additional increases in speech and language difficulties that were observed? You discuss these at paragraph 22 to 28 of your statement, and you discuss there some of the surveys that the Royal College of Speech and Language Therapy conducted.
So in addition to the Public Health Scotland evidence, we did a survey with Early Years Scotland, where they support early years practitioners working in nurseries across Scotland. We had 245 responses to that survey, and 89% of respondents said they'd seen an increase or a significant increase in the numbers of children with communication and the complexity in which they presented. They also highlighted the impact that was having on children, so they said it's impacting their ability to participate, to make friends, to learn. They're seeing more behavioural issues because of it and more challenges with the children's mental health and well-being. So, and anecdotally, we've heard from our members and teachers that they're seeing a very significant number of children coming to school who have very little language, if any, at the P level, and they're raising high levels of concern about that.
Thank you. And just some of the reasons for these increases, I think probably mirror some of what you've already discussed, but you discuss those at paragraphs 25 to 27, and you attribute these changes that have been seen to factors such as reduced opportunities for interaction and exploration, decreased access to critical services like education and speech and language therapy, and challenges experienced by families, although some of the challenges and issues you've already described in relation to.
Yeah, I think so. The one thing I would add to that is that the lack of we know that education and the opportunities to play and engage and play alongside children are very important for child development within the educational context. Now, within the educational context, they still need to experience regular interactions with others and that conversational exchange in order to make promote their language development. But if they do experience that, that can be a very good thing for their language development.
And I think you've already touched on it. Presumably some of these needs would have been experienced regardless of the pandemic in relation to certain children. And I think you've already indicated that the consequences of the impacts of the pandemic are that some of these are more complex, that you're seeing that maybe would not have been as complex but for...
I think the pandemic exacerbated an already urgent need around children's communication. Even the data around health visitors at 27, 30 months, which will underrepresent those with communication needs that come more apparent later on. But in areas of deprivation, they were seeing double levels of concern in those areas.
And why are they more complex?
So some of the needs are more complex because children with who were born with some of these risk factors, environmental factors also affect them. So if they haven't had exposure to all of the things we discussed, they will experience more challenges and more complexity. I think the complexity comes from having not had access or having to wait for a long time to access services. So if you like, for want of a better word, if they haven't had support that they needed or quality advice, then the level of harm will have increased, and therefore the complexity will have increased in those needs over that time.
Thank you. If we could then turn to discuss the issue of the redeployment of speech and language therapists in Scotland, which you discuss at paragraphs 29 to 34 of your witness statement. Could you please describe the extent to which... Could you please describe the extent to which speech and language therapists were redeployed to other healthcare roles during the pandemic, and how this impacted on the provision of services for children and young people?
Yes, the redeployment of speech and language therapists was variable across the country. Most services did have an element of redeployment. Some were almost stopped entirely and switched to adult services. They were redeployed into a range of roles. Could be vaccination clinics, it could be intermediate care, it could be acute settings. Depending on the skills of the speech and language therapist, they could use their eating and drinking skills in an adult setting, an acute setting, although there was obviously anxiety around that. Some were deployed as nurse auxiliaries into adult services to prepare for what we saw coming into the pandemic. And I think most services maintained some level of offer for the most urgent requests, and that by that I mean eating and drinking. So if a child was concerned about a child choking or not managing liquids or solids, then they would be able to go and see those children. So we maintain that level as a core offer. Now that was challenging because we know that some of those children tended to have more complex needs or physical and were vulnerable and therefore were shielding. So therefore parents had anxiety about someone else coming into the home or going to a central hub. But speech language therapists navigated that. So speech language therapy, there was a lot of redeployment out of children's services into adult services at that initial time.
And what was the reason? What were the reasons for that redeployment?
The reason we think is, initially we didn't really understand COVID. We had some level of understanding that it affected adults more than it affected children, and therefore there was decisions made locally to redeploy staff to ready the system so the system didn't collapse, if you like. So I think the reasons in part are in that they deprioritised children's services and didn't foresee perhaps the impact it would have on children.
And how did the Royal College of Speech and Language Therapists view the decision to redeploy therapists, and did that change over time?
Initially, given the lack of understanding of this, the Royal College wanted to be supportive and therefore were supporting our members in terms of redeployment and were open to that. I think after time, what we were hearing from the members was that their skills weren't being fully utilised. They're highly qualified, they've got lots of skills in which they could be utilised, but and also the concerns from our members about the harm that would be occurring for the people that they normally serve. And so at that point, once the initial phase was over and we were hearing feedback from the members, that was when we were encouraging government to bring those speech and language therapists back to their core roles to be able to serve the children and young people with communication and swallowing needs.
We'll touch on a bit later about the increased waiting times that we're seeing now, but to what extent did this redeployment contribute to the increased waiting times that you described later in your statement?
Given that it was variable across Scotland, but typically I would say it had a very big impact on having to pause the majority of services, and therefore we weren't able to reach families, had a very significant impact on waiting times. There's other aspects of that will have impacted waiting times, but the redeployment will absolutely have caused a pause and therefore a backup of need.
Thank you. I think you've already touched on this, but what types of speech and language services for children and young people continued to be delivered in person, and how were they delivered? I think you mentioned highest priority was given to people with complex needs, and you mentioned going into homes. What was the full sort of range of face-to-face?
So the face-to-face offer, depending on where we were in the pandemic, the key thing that we tried to maintain was that offer of eating and drinking, because whilst we could do some telehealth on that, it's important to get close to the child and to hear and observe and to touch, to check on their swallowing, because that is such a critical area and high risk. Other offers were telehealth. Now, it depended on how well set up services were, whether they had access to IT, iPads.
Was that a face-to-face, or was that...
Oh, sorry, so no. So most of the face-to-face stopped, depending on when we were in the pandemic. As it opened up, we would prioritise some face-to-face that needed to happen. That could be around speech sound difficulties, or the highest need of kids who are really struggling that needed therapy as soon as possible. But the lack of face-to-face will have affected how effective the interventions were, and therefore how quickly we're able to promote improvement.
And then you mentioned the telehealth. Could you please describe that and some of the other remote offerings that were provided?
So telehealth obviously is reliant on both sides having access to IT equipment. Now, some areas in Scotland for speech and language therapy services, they didn't have access for a very, very long time, which obviously impacted their ability to provide telehealth, which is basically the family on one side, you on the other side, and you can do a bit of assessment with the child if they're of an age. You can observe the child, you can promote, you can coach and model, you can coach the parent. So the therapists were very quickly adapted to that, provided lots of high quality as they could approaches and interventions remotely if they had the IT equipment. The challenge would be on the other side as well, whether the families had access to Wi-Fi or the adequate IT equipment to facilitate that, and that wasn't always the case. So telehealth was an offer which we rapidly moved on. We also relied on phoning all staff, all people on the caseloads to talk to the parents and give advice and strategies and reassurance. But also we had, typically a lot of the services had good social media presence, and the demand for that increased significantly during the pandemic, with parents keen to access high quality advice and strategies for their child, to be signposted to good resources online, and speech language therapists spend a lot of time developing videos and signposting to the best information online that they could offer at that point.
Thank you. You mentioned sort of the issue of whether or not parents were able to access because of digital inclusion issues. Was there any evidence of literacy levels and language skills of parents impacting on their ability to access services, specifically speech and language services for or on behalf of their children?
Well, I only have anecdotal evidence about that. We know, however, that parents with literacy difficulties, but also children, parents with communication difficulties, because this quite often is an intergenerational cycle of parents with communication needs and their children with communication needs. So sorry, I've lost my train of thought. What was that?
It was about whether there was any evidence for literacy levels and language skills of parents impacting on their ability to access support, and you were mentioning the intergenerational issues.
So literacy difficulties absolutely impact people's ability to engage with services, as does communication needs, as well as poverty, as I've mentioned before. But that I only have anecdotal evidence that could be a challenge. But also families with additional language, who we did have access to interpreters during that time, and utilise them and try to facilitate three-way conversation with additional organisation, which is possible, but made it a bit more complex to ensure that those families' needs were being met.
And again, just in terms of when you were describing the in-person continuing and that being for the highest priority being given to ones with complex needs, what sort of priority level were these other offerings, these remote offerings, being delivered to? Was this available to everyone, or was there an order of priority?
So for services who were able to maintain a certain level of resource and who weren't redeployed and had to pause significant aspects, it was an offer to all those parents and families. For those who had less of an offer or resource, then they did need to prioritise which families they reached out to. Some weren't able to prioritise very many children at all because they didn't have the resource available, but typically these were an offer where interestingly, I think sometimes in the initial stages the parents felt that there wasn't a service. They just assumed that there wasn't a service available, so they weren't reaching out, and therefore it was imperative that speech language therapy services reached out to them and made it aware on social media if there was an offer and what that offer was.
Yeah, thank you. If we could turn now to discuss briefly the impacts on mental health and well-being, and in paragraphs 37 to 39, you discuss a number of surveys that were carried out during the pandemic that asked specifically about impacts on children and young people in relation to mental health and well-being, and that was as a result of a reduction in speech and language therapy. And I think these were ones that were conducted by the Royal College of Speech and Language Therapy. Could you please outline the concerns that were identified by or on behalf of children and young people in relation to these impacts on mental health and well-being, and also explain what the connection is with the reduction in speech and language therapy services?
I think we've got very high quality research to show the connection between children's vocabulary, for instance, or communication, and mental health and future life, but also their mental health at the time. These were snapshots, so there are small surveys, but we did survey parents just to ask about the impact. We know from some of those surveys that 1% had experienced telehealth prior to the pandemic. The 87% said they received less speech and language therapy during the lockdowns and during the pandemic, and 63% said they didn't receive any specialist level speech and language therapy or any speech and language therapy at all. Now, it depends on your interpretation of what speech and language therapy is, but because some elements were continuing within educational placements that were reopening. However, in terms of the mental health, when we asked parents the impact of not receiving speech and language therapy, there was a few things they identified. They identified that it was an impact on children's ability to make friends, their ability to access education when they were there, and on their mental health. We also had surveys for our members who were identifying high levels of concern of children not accessing speech and language therapy on their children's mental health and their behaviour, which is all connected. So in terms of the connection, it's multifactorial. I suppose what we see is that there's an element of what speech and language therapy do to reassure parents, A, that they're doing the right thing, or to provide real solutions to adapt the environment, the home environment, and to promote spoken language, and so parents can see improvement. When the parent is anxious and is poor mental health, that obviously influences the child as well. But if the child doesn't have the right strategies and advice, whether that's at home or in school, and they experience those barriers and the disconnect in terms of relationships, then what you see in the surface quite often is behavioural difficulties, and some children will give up, if you like, in terms of learning, and then find other ways to engage and get attention. So that's the sort of connection. And so speech and language therapists are there to unlock some of the challenge, to understand the communication and to know what works to facilitate that need. Sometimes that involves improving the communication. Sometimes that's a strategy which can support the child to flourish in the environment that they're in.
Thank you. And I think you said paragraph 37, one of the surveys carried out asked questions about this issue. The key pieces of information that respondents shared with us were around the impact that the loss of speech and language therapy had on social life and friendships for children and young people, followed by access to education, then impact on home and domestic life, and finally their mental health. And again, all tied presumably to the loss of speech and language therapy.
That's right.
Then you go on in paragraph 38 to say in the same survey, we also asked a question about the impact on the family more broadly. So is this not just specifically on the children and young people?
I think this points to the issue that when there's one of your children is struggling and one in a significant area of life, parents instinctively know how important communication is, and they worry about their child's communication. It's the one area they seem to worry about most, and that's because of what I've talked about, how important it is in terms of connection, expressing love, and their hope for the future. And so more broadly, when we're asking questions about this, parents will quite often mention about this is having a big impact on our family, on how we function, how we access social, what we decide to do and what we decide not to do, and the stress of a child accessing education.
And then in the next paragraph at 39, you talk about a survey done in 2020 where you surveyed your membership to ask them about the impact of the pandemic and lockdown on children and young people with communication needs. And so was this asking the similar questions, but of your membership of the practitioners?
That's right.
And you say the respondents to this survey noted deteriorating mental health and an increase in challenging behaviours. So again, similar to what were being reported by the parents and children and young people themselves.
That's right.
You also mention the respondents also raised concerns about barriers to accessing service, about the deterioration of communication skills and swallowing needs, and an increase in safeguarding concerns. What were those specific concerns in relation to safeguarding, if you can remember?
Yeah, I think this, I am assuming this relates to isolation of families and whether safeguarding concerns. It's a general reflection on the concern of what will be happening with children when we're not able to get access to public services or schools or education. But I don't know specifically about the detail of that.
If we could then move on to discuss the issues around schools reopening and operating with restrictions. When education settings reopened with restrictions, what access did speech and language therapists have to children? And probably thinking more about the ones where the services were embedded in schools and then separately ones where they weren't.
So again, this was variable across Scotland. Different local authorities interpreted the guidance differently, and interestingly, it would seem that those services who were more embedded pre-pandemic and had a close relationship and were viewed as a core member of the team got access to education far quicker than those who were seen as an external agency who were kept away from education settings. So for services where there's established relationships, they got in very, very fast or reasonably fast. And then for those who weren't or didn't have as close a relationship, then it could be many, many months before they got anywhere near an educational placement. And that was a concern for us. And
just in terms of the concern, was that in relation to impacts of children not being able to access those services?
Yeah, that was in relation to knowing how important partnership working is and a multidisciplinary approach to meet the needs of children and to ensure that children are accessing the highest quality services and overcoming barriers. And so it's about the connection and how important communication is for children to access educational establishments and deliver on the outcomes that you would hope them to achieve in the education setting.
In terms of some of the practical challenges, you discuss at paragraph 42, challenges that the use of personal protective equipment had for speech and language therapists and their ability to do their job, and you also outlined some of the difficulties or tensions that arose in relation to guidance and different guidance for health practitioners and educators. If you could please just elaborate a little bit more on some of those concerns and challenges.
Yeah, obviously there was different guidance for health professionals versus education, and so what our members found was that as a health professional you had to follow guidance which is far stricter, which you might expect, but that given that they were working in an education context, that meant that they were going in with full uniform, sometimes full PPE, apron, mask, gloves, compared with their education colleagues who may be wearing a mask, for instance. So this actually caused some tension and anxiety on both sides, where educators were wondering why the health staff were wearing so much PPE and they weren't, and also from the health staff feeling this felt like a barrier to the job they were trying to do. In part, it was reassuring to educators that our members were supporting education to explain that we were being careful. We weren't visiting too many places, or one, or if at all, before coming to their educational placement. But the fact that there was different guidance and speech and language therapy in this position where they straddle health and education, it became a barrier and got in the way of our partnership working when we did manage to get back into education.
And were there any discussions around that at the time?
Locally, there was, as far as I can tell, and having engaged with lots of speech and language therapy leads, they had local negotiations. Some local authorities took a harder stance. and others negotiated. So it was about trying to come up with a pragmatic solution. But also you're trying to manage the anxiety of staff on both sides. So that was a tricky situation to be in. But yeah, I would say there was quite a lot of local negotiations on that.
Thank you. I think if we could then turn to look at some of the ongoing impacts, and you mentioned specifically at paragraphs 43 to 47, increased waiting times for speech and language therapy post-pandemic. Could you please explain a little bit more about that, and in particular what the current waiting times are for speech and language therapy for children in Scotland?
We started to hear anecdotally that the waiting times for speech and language therapists were very high, and so then therefore in May 2023 we sent a comprehensive freedom of information request to all services in Scotland. At that point the information came back demonstrating that there were 6,503 children waiting for speech and language therapy. The average wait at that point, the average longest wait for initial contact with the therapist if they needed it was 1 year, 1 month. The average longest wait at that point if they needed therapy was 1 year, 5 months. Now, we also asked for data across the last 5 years, which allowed us to demonstrate the increased wait during that period. So we were able to show that the wait over the last 5 years for initial contact for speech and language therapy had deteriorated significantly and had increased by 8 months in those last 5 years. For wait for therapy, it increased significantly, and the average longest wait had increased by 10 months over those last 5 years. So the wait was very significant, and we refreshed some of that data in May 2024. There are more children waiting for speech and language therapy now at 6,727, and the waits are variable though. So some areas they could wait for 12 weeks, in some areas it's more than 3 years. But for the data we have most recently, is the longest wait was over 6 months for 50% of the health boards in Scotland. And the reason that is very significant, which I alluded to earlier, is that for children's development, that level of wait is like a lifetime, because they're doing so much development during that period compared with an adult waiting for something similar. So that is a particular concern, because they're not getting the support they need, and they're developing, or they should be developing rapidly during that period.
Thank you. And just you've touched on it, or some of the reasons, but what has contributed to this increase in waiting time?
I think what's contributed to the wait is that services were paused. For some services that was a significant wait. Speech and language therapists were deployed. It was harder to get to children face to face, so actually progress for children, and therefore throughput, if you like, was delayed and restricted. In addition to that, we've got recent freedom of information requests to give us insight into the capacity in the system for Scotland to deal with this number of children. So we know that the increase in speech and language therapists headcount in the last 5 years has increased by 2% in Scotland, but compared with the rest of the UK have increased the headcount of speech and language therapists on average by 15%. So the capacity in Scotland is a concern, and shows we were able to highlight that also will be affecting how quickly we can get to children and meet their needs.
And again, you've touched on this already, but given what you've already told us about the impact of the pandemic on restrictions on children's communication and language skills that have already been observed, and how important early intervention is, how concerning are these waiting times for the profession in terms of outcomes for children and more generally?
I think that our members, speech and language therapists, know this better than most. They don't want children to have to wait a long time, because they know how urgent it is to see some of these children, and trying to express to those people in the system why this wait is far too long, and they are trying to do that, as are we. I think it's been described as a public health crisis. I think as I've expressed before, there was a concern pre-pandemic. The pandemic has worsened this, and we're concerned that we don't have the resources in Scotland. We do need to do the transformation in Scotland to support new ways of working, but you need a threshold resource to deliver that. And these are real children we're talking about, real children who are experiencing harm, and therefore there is an urgency about supporting the children who've experienced this and supporting their improved needs, but also other children who are coming through. So the outcomes are clear, research is demonstrating how important it is, and we need to take it seriously and address it as soon as possible.
Thank you, Mr. Carter. I'm going to come on just finally to some of the lessons to be learned, but one moment, please. Mr. Carter, then finally, you have from paragraphs 51 onwards to the end of your statement, you identify some potential lessons to be learned. If I could just ask you to go through those and just elaborate where appropriate on any particular ones that you'd like to draw to the inquiry's attention.
There's a general one about the eating and drinking and swallowing, about protective equipment for members. I think for a while, for a period during the pandemic, we were making the case that coughing is an aerosol generating procedure, and therefore our members needed to be protected against that, because when they're dealing with people with eating and drinking needs, they're getting very close. When you choke or cough, if you've got a problem with your swallowing, you're more likely to cough, and we're seeking the highest level of protection, FFP3 mask. So that's a key lesson, I would say.
And just pausing on that, you spoke about difficulties of wearing PPE when trying to do the job of providing therapy. Were these special masks, the transparent masks, face coverings?
So, well, for speech and language therapists working with children with or adults with dysphagia, i.e. eating and drinking difficulties, the transparent mask was less important because they were just needing to get close to them to be able to touch their neck, to feel the swallow, and to assess that adequately. For children with communication needs, and indeed particularly speech sound difficulties, transparent masks are critical so the child can actually see what you're doing with your lips, your tongue, and so therapists did get access to transparent masks. It was quite a long way into the pandemic before we got that, but that is a key learning for if this was to happen again.
And then I think the next one you have relates to the redeployment issue. You say that after initial lockdown period, it would be useful to have had a period of reflection. The best use of the workforce should have been reconsidered, and staff should have been returned to services where their skills would be of most value. Do you care to elaborate on that? I assume that relates to the redeployment issue, but
yeah, I think that once the pandemic was understood and it became obvious what was happening, we would want to avoid deprioritisation of children's services to ensure that the harm didn't occur. And so our strong recommendation is that children's services are protected and that speech and language therapists stay in their core role to be able to meet the needs of these children.
And then you've got at paragraph 54, again refer to maintaining children's services and, more importantly, maintaining an integrated, a level of integrated teams around children. Do you care to elaborate on that potential lesson?
I think the interesting thing about the pandemic is that it shone a light on how important it is for services to be fully integrated, to be close to each other. And so a rigid view of speech and language therapists as a health-only service got in the way of that in terms of guidance and our ability to engage in an integrated manner. And services who recovered more quickly and who saw improved access were those who were more integrated prior to the pandemic. So this is a key lesson about the importance of speech and language therapists being embedded within educational placements.
And then at 55, I'm not sure how related this is to the previous one, but you talk about therapy services that remained most effective had adopted a preventative approach pre-pandemic. Could you please elaborate a little bit on that?
Yes, so services who had delivered transformation pre-pandemic and who were working in that whole system approach, which I described around universal, targeted and individualised, observed that even when they weren't able to get into an educational context, that some of that work could continue, even if they weren't there. And that was the whole point of being able to prevent harm and continue work and support and provide a sustainable approach to some of these needs. So that was the point that we were trying to make there.
And was that work ongoing, being delivered by educators, by teachers and...
That's right, early years practitioners, and because they had the skills and the approaches and the knowledge of particular interventions, then that would have continued in even as a whole class offer or a small group or even individual.
You've made the point very clearly in your evidence about how critical children's spoken language skills are in respect of their outcomes. Is there anything you'd want to add to that lesson that you've got in paragraph 56?
I think it's been the awareness in the general public and in the system of how important communication is relatively low. The pandemic clearly showed the exacerbated need. It highlighted how urgent it is to address children's spoken language, and that this is a public health crisis, and we need adequate levels of speech and language therapy to serve these children in an integrated manner. And I would hope the lessons learned are how critical communication is for children's learning and how it can be promoted, and also what gets in the way of it.
Thank you. And then just finally, you say it's important, we need to learn the lessons and develop a nationwide approach to meet the needs of children with communication needs. Why is a nationwide approach important?
I think there's learning across Scotland. So we're actually working with a collaborative at the moment to identify the principles for transformation across Scotland. So that collaborative includes the Association of Directors of Education, COSLA, the Scottish Directors of Speech, Allied Health Professions, Children's Speech and Language Therapy Needs, and we've identified clear principles for what needs to happen, which includes prevention. It also ties that together with adequate resource, and we're speaking to the Scottish Government about that. So there is an opportunity to take a nationwide approach to this. You also need, though, to identify the local needs. So the needs of those in Orkney might be different from inner city Glasgow. So there's a Once for Scotland approach, but actually you need the ability to adapt the approaches and resource to the needs of that local community.
Thank you, Mr. Carter. And then finally, is there anything else you'd want to add to your evidence in relation to either lessons learned or otherwise?
No, thank you.
Thank you, my Lord. I have no further questions unless your Lordship has any.
Thank you very much indeed, and thank you, Mr. Carter. That's
Thank
all.
you.
We'll now take a break until, well, a little bit longer than we'd planned, till 1:45. Very good. All right. Thank you.